Good afternoon. It's a privilege to be back here this year and amongst some very distinguished speakers. For those of you that attended New Zealand last year for the CAA, you might recall that I presented on the stroke pre-hospital informed decision-making using EEG recordings. We've since rolled out that study and have completed data collection and are in the analysis phase. We met our target recruitment and the preliminary results are promising, and I'll get into those in a little bit. Now, most of my PhD and most of my studies is in the stroke field, but as we were doing this EEG work, it became quite apparent that the role for EEG, and I'll explain, obviously there's complexities around EEG, and I'll explain why I think the pre-hospital environment could benefit from this. But it certainly can cover more than just stroke itself, so a multiple use tool would be of great benefit to paramedics. So if you consider your brain as essentially the consistency of soft tofu or gelatin, during a high-impact collision such as this one, your brain's forced forward against the rough inner surface of your skull, similar to these glasses against the car. What will occur is the primary injury is at the point of impact. The secondary injury that then occurs from there involves the bleeding and the inflammatory process thereafter. Not too dissimilar to what we're going to see here. So obviously, because the grey and the white matter are slightly different densities, there's a shearing of axons during this force, and you get the diffuse axonal injury as a possibility in traumatic brain injury. But also, if the shearing forces are great enough, you can get a disruption of the vascular flow and a bleed into the brain, which then has impacts in terms of intracranial pressures and affects the cerebral blood flow. Now consider the patient's journey of this patient here that's had this traumatic brain injury. What would typically happen is, as we heard earlier from Professor Loudon's talk, that this thing called impact brain apnea can occur, and that can cause early death if not corrected, and can be corrected quite simply even with bystander or first responder care. Potentially this patient has a bleed like we saw in that video. The paramedics are going to arrive and we're going to try and optimize airway, we're going to try and optimize oxygenation, and we're going to try and optimize perfusion in terms of blood pressure. In a lot of systems, with a severe traumatic brain injury, we'll instigate rapid sequence induction or intubation as a neuroprotection management plan. And then we can obviously adjust our ventilation or etc. to improve airway, the oxygenation, and certainly the cerebral perfusion. What we don't know is, in these post-traumatic head injury patients, is if they have a seizure. Once they're paralyzed and sedated, we don't know if they're having a seizure. We know that when you have a seizure, the metabolic demands in your brain increase, and intracranial pressure can increase as well as a whole host of other effects that are deleterious to the patient. But currently what we look for is signs of herniations, the really obvious signs. And you can have increasing ICP without any clinical signs in the early stages. So it's only when we see that herniation that we start to see the signs and symptoms, blood pressure increase and the heart rate decrease and irregular respirations and unilateral pupil dilation. It's at that point that we'll then institute something like hypertonic saline to decrease the pressure, the ICP. We'll then transport the patient, deliver them to the ED, they'll be assessed, they'll have their CT scan, and they might meet a neurosurgeon depending on the results of that. So when we talk about neurocritical care, although I present a case of a traumatic brain injury, it obviously includes other things such as aneurysmal hemorrhage, acute ischemic stroke, ICH, status epilepticus, encephalitis, etc. And these are all patients that we do see, but for many of them we can't obviously identify and differentiate unless there's a historical history that suggests otherwise. But what we want to do is prevent the secondary brain injury. We want to prevent the hypoxia. We want to prevent the hypotension. We can prevent the hypercapnia in terms of ventilation management, and obviously we can detect hypoglycemia and treat that. What we can't tell is if the patient's ischemic, has ischemia, cerebral ischemia. We can't tell what's happening with cerebral blood flow, and we can't see the rising ICP until we get to the point of herniation, and we can't tell if they've got a seizure. Obviously, acidosis, we can manage that to some degree in terms of, as I said, our ventilation management, etc., but we can't really measure that, and it's unlikely to change at this point. We've heard a lot today about, in a macro sense, if we can't measure something, we can't improve it. So I brought that back to this and started thinking, well, if we can measure what's going on within the brain during these neurocritical events, can we improve it? Is there something more we could do that could improve the outcomes? Because many of these patients have quite poor outcomes. So in an intensive care setting or a neurocritical care setting, there's a few monitoring modalities that you can use. You can use the direct measurement of ICP. Obviously, that's quite invasive and not something you're likely to do in a pre-hospital setting. You can do transcranial Doppler ultrasound. It requires a bit of skill to do and perform, and you can obviously detect rising ICP through that as well. Near-infrared spectroscopy has been investigated in the pre-hospital setting, and I'll talk a bit about that a bit later. Microdialysis, once again, it's obviously invasive, not something we're going to be doing. And EEG typically has required an expert to interpret. It's quite hard to do. So it's been limited, but it's considered a very important part of neurocritical care. One thing with talking traumatic brain injury is optimizing sedation. We know that if we optimize sedation in an ICU setting, that it improves cerebral tolerance to ischemia, it improves the outcome. It controls the ICP by decreasing cerebral blood flow, and it gives us a degree of seizure suppression. It's very well established that optimizing sedation improves outcomes in shorter periods and length of stays in ICU. But if you're a bit overzealous with your sedation, you can also have a deleterious effect on your patient. You can decrease the mean arterial pressure, induce myocardial depression, peripheral vasodilation, and obviously the effects on the brain-injured patient. So there was some work done quite a number of years ago looking at the bispectral index monitoring for sedation. Now, unfortunately, that was taken up in the anesthetic setting quite well. Unfortunately, it became very, very apparent that although you could do this measurement, it actually wasn't highly recommended for sedation monitoring. Certainly, there's overlap and inconsistencies with it. But what they've seen more recently is that it's very specific to, obviously, the drug agent you're using. If you're talking about EEG monitoring, depending on the agent that you're using, propofol, ketamine, etc., they have differing effects on the EEG. So when you start to get it down into the detail, perhaps based on the drug or the dosage of the patients delivered, that can alter the EEG patterns. So what if we were able to start monitoring early and we could optimize that sedation, so we could improve that patient's, not only their experience, but certainly the hemodynamic effects of our drugs, rather than just having a very blunt approach to our management of sedation for the RSI. Would that improve outcomes? Then we move on to seizure. So seizure, if you think about it, is just an arrhythmia of the brain. So we'll monitor the heart post-insult for arrhythmias. So why don't we do the same for the brain? Now, EEG is well established in seizure assessment and has been for quite a long period of time. What this consensus statement states is that, and this is an ICU setting, is that continuous critical care EEG monitoring is important, and that they can pick up ischemia, and more importantly, that quantitative measures, and when we talk about quantitative measures, we're talking about converting raw EEG into ratios, percentages, numerical values, basically, that don't require a lot of training to read and can give you a gauge of how the patient's going in real time. And certainly that's been done in the ischemia space, and I'll get onto that in a second. Obviously, they can also pick up non-convulsive seizure activity. Now, when you start looking at the rates of non-convulsive seizure activity, and especially in the patients, so obviously they're paralyzed and sedated, you're not going to see this. You can see here that in the status epilepticus patient, the patient that you believe you've stopped that seizure on, however now paralyzed and sedated, they still had rates of up to 48% of non-convulsive seizure. Moderate to severe brain injury, that was up to 33%, and even an acute ischemic stroke up to 27%. And we know the deleterious effects of this non-convulsive seizure activity on the brain and the brain injury. So, assume we're monitoring this patient now, we can pick up this seizure activity. Would we intervene? Will we provide further burst suppression or seizure suppression? And would that reduce the likelihood that they progress on to that rising ICP and that herniation? So, another important part of care is managing that intracranial pressure, but we can't measure it. It's very invasive, obviously, routinely in the ICU. It's not something we want to do pre-hospital. And the clinical signs, as I said earlier, aren't immediately apparent as the ICP is rising until you get to the point of the herniation. So there's been some studies looking at monitoring ICP in the brain-injured patients. And they found that obviously there's a neurovascular link. And often what you can see is that as there's a burst of EEG activity, shortly followed by a rise in ICP. So there's definitely this causal link or correlation. And obviously with rising ICP and pressures, you can get reduced cerebral blood flow. And it certainly, and I'll show you in a second, we talk about cerebral perfusion being assessed by EEG. Once again, there's preliminary research that's looking into the different quantitative measures within EEG that could be used for identification of rising ICP. So it's not about reading the raw EEG activity. And this is looking forward into the future. It's not necessary for right now. So assuming we could detect that rising ICP even before the patients started to herniate, and we institute some hypertonic saline, for example, and we reduce that ICP, and we improve that cerebral perfusion, they don't herniate. Okay, so they don't get as bad. So that's great. Patient does a bit better. What about neurosurgical intervention? Now, we heard earlier the paramedic of the future talking about burr holes, pre-hospital, etc. And obviously, this is not, in this setting, is not necessarily about detecting the location of the bleeding, depending on your EEG placement. But what they did in the US is they looked at EEG activity in minor traumatic brain injury who had a higher GCS, and more as a triage tool and a decision tool on whether to do CT scanning. And they found that, as we probably well know, is in traumatic brain injury, a lot of people get the CT scan. That's how you decide whether they've got a vascular or hematoma. TBI was diagnosed in 52% of those, and only 9% of those evaluated had actual evidence of traumatic abnormalities. So what they did with this EEG, and it was a handheld device, it's marketed, it's currently in use in some places, and they found that they had quite a high sensitivity, a little bit of a low specificity, but they reckon they could pick up greater than 1 ml of blood to a sensitivity of 98.6%, which is pretty good. Obviously, that's ongoing work. But what they said is we can reduce the number of CTs we're putting people through with this. And that's the space. And the question is, are we going to see the similar or better results with a severe traumatic brain injury patient? So what would you do with that information then? If you could identify that, yes, the patient has a hematoma, what does that change? Well, potentially, maybe, we do burr holes one day. But even if it's just that it speeds up the process, we've heard all about how processes are important and how our activation in the pre-hospital setting can improve those in-hospital processes. So perhaps being able to say with a high degree of certainty that the patient has an intracranial hematoma, we can bring forward that CT, we can bring forward that neurosurgical intervention, especially in the case that if they are herniating, that's obviously quite critical that we reduce that pressure. So cerebral ischemia, and this is where the stroke side of the study gets involved. So there's a lot of work done in the Royal Brisbane Hospital initially, and it was published here, as well as in other places. And we found that using quantitative measures, you could identify cerebral ischemia. Obviously, the mechanism was stroke in these studies, but the principle applies across any cerebral perfusion factors. So what you can see there is that with increasing severity of stroke, they're able to see, using, in this case, a delta alpha ratio. So as I mentioned, it's a ratio. You could see that you could pick not only, obviously, the location of the stroke to a high degree, but also the severity of the stroke. And as the stroke was more severe, you could certainly see the increasing numerical value of the delta alpha ratio. And they did that in pre-hospital, in hospital studies. And they thought, well, let's do that in pre-hospital and see what we can find. And that's what we did in Brisbane this year. So what we know is as the brain becomes more ischemic, or the cerebral perfusion reduces, the FOST activity, which is a healthy brain activity, if you like, starts to decrease. And the slow or unhealthy, or the delta waves, they start to increase. And it's that ratio that indicates the ischemia. So I said about some preliminary results. So as I said, we met our initial target. As what Sky was saying with the AMPDS, it's a highly non-specific tool for identifying stroke. So of everything I attended, only about 30% ended up being recruited. That didn't guarantee it was stroke, obviously, but certainly that was what got recruited into the study. So what we got here is a comparison of two patients. So I assessed both these patients. As it was, I ended up as the data collector or the research paramedic in the study in the end. Interestingly, the side effect was I got a new nickname as Spider-Man, because that's the acronym of the study. So these two patients presented very similarly clinically. But as you can see, the patient that ended up being diagnosed with a large vesical occlusion, that delta alpha ratio, that EEG abnormality was much higher in the early treatment of this patient versus the non-LVO patient on the right-hand side. As I said, they presented very clinically similar. And then when we got a group of 10 patients together and we looked at, there we've got 2 that had LVO, 4 that were non-LVO stroke, and then mimics or resolving TIAs. And you can see there's a trend there. Now, obviously, this preliminary data, there's further analysis to go, but certainly the trend was promising, and as I said, we're analysing the rest of that rest of that data at the moment. So what if we could monitor the cerebral perfusion throughout the treatment of this patient? Would that then guide our treatment? Would we then instigate change of ventilatory management plan or instigate other medical treatments to improve the mean arterial pressure, to improve the oxygenation, and to improve the cerebral perfusion pressures? And would that make a difference to the patient? Would measuring this stuff make us change our practice and improve the outcome for these patients? I don't know what the answer is, but that's what research is for. Now, in terms of interpreting EEG, see all those arrows up there? I have no idea what any of it means. Because I'm not an EEG expert, and I don't presume to be. And that's why, moving into the future, we're going to talk a lot, and I think tomorrow someone's presenting on artificial intelligence and what role that has in a medical investigation. So this has already been done looking at the use of AI for epileptic seizure detection using just scalp EEGs. And what they found is that they were able to do it with a reasonably high level of sensitivity and specificity using this AI algorithm. It's still under development. There's still a lot of research to be done. But looking forward into the future, we can start leveraging off technologies that use AI that are at the moment quite complex to perform. But using AI, you can just about get anyone able to use them. In terms of transforming healthcare with AI, there's a significant number of current and emerging companies that are looking into that, as well as obviously academic organizations doing the research. Healthcare published in 2016, there's a lot looking at AI use in healthcare, and certainly ECG and EEG does feature there. So I mentioned NIRS just before, so many of you will be aware of the studies that have been done pre-hospitally looking at the use of NIRS, which is essentially SpO2 for cerebral perfusion, or cerebral oxygenation, I should say. Similar principle. But what they've used that to be is also a measure to see if they could detect hematoma, and up to about 2.5 centimeters into the brain, they could see a reasonable degree of accuracy if a hematoma was present. And that research is going on. Anyone from New South Wales will be familiar with Andrew Weatherall, and he's doing some of that research looking at NIRS. They have had challenges, environmental challenges that are going to occur in the pre-hospital setting, but they're certainly working further into that. Not just them, but other places around the world. I won't speak too much about it, but we've noticed our colleagues in Victoria have now started investigating other mobile technologies, including microwave, which you see on the screen there, to identify the bleeding patient. So I don't assume that EEG is the only answer to everything. Certainly a combination of technologies with the use of AI and interpreting. Potentially that's where we go to in the future, but having the real-time management or the real-time information in front of us, if that changes the way we manage these patients, do our outcomes improve? So obviously, this is not just all pie in the sky thing. Research does need to be done, but it's not just up to the paramedics to do it or the pre-hospital providers. So obviously, this is in the early stages, but potentially if we do this research study looking at EEG and traumatic brain injury, it requires a lot of experts in a lot of spaces, neurosurgeons, neuroscientists, neurophysiologists, neurologists, as well as pre-hospital experts, whether that be doctors or paramedics, trauma surgeons, etc. So that's where we're hoping to go with that. So perhaps we can get the information and just start the conversation. Is this of any benefit? Will it show us what we think it will show us? Thank you for having me.